faculty with Dr. Mohan Nair, who is a course director, and Dr. Ravin Chakrabarti and Salvaraz and my colleagues. It is a moment that I can't forget, and let me not waste the time. The topic is regarding the drug treatment of resistant ventricular tachycardia. As you know that when we say that ventricular tachycardia, it is not a pain only for the patient, but a doctor up to a level of cardiologist, he becomes very much nervous what to do next. And when it comes for the treatment point of view, I think probably the electrophysiologists, they are a bit comfortable, but after ablation, if it is recurrent coming, then it become a pain for them. And then we try to what you call tide over with the medicines, and there it comes the role of medical management. And coming to the resistant, yes, this is most difficult part, but going before in detail, let me come to the principles of management and what is the pharmacological options, and I will walk through some of the cases which are interesting and which will give an insight regarding the pharmacodynamics and pharmacokinetics related to the drug treatment in the practical sense. So when it comes to the VT, we are having the options of we are having three options. That is a medical management, antiarrhythmic, second is the ablations, and third is the device. And we just walk around each option depending upon the patient's situation. Most of the time, medical management is the first treatment, and when patient stabilizes, we give the option for the device therapy versus ablation. And some patient, the ablation may be curative. In some patient, we give ablation as a add-on therapy to the device therapy when the patient is developing recurrent VT. So how to decide that which patient is going to need drug treatment and which patient is going to need a device therapy, that becomes important. So when we are dealing with the VT with normal heart means patient is having no structural heart disease. So these are the two classification we usually take care. Means if the patient is having VT which is originating from outflow tract, or it is a fascicular VT, or VT in the cases of Brugada, long QT, CPVT, or idiopathic VF, there the treatment is mostly we call as a ablation. And when the patient is having structural heart disease, the first option is always the ICDs. And if ICD is giving recurrent shock, or the patient is having recurrent VT, then we are going for ablation. And word structural heart disease is a something, sometimes it is question what to say structural. So if the patient is already having heart disease with a heart attack, and or we can say myocardial infarction, it is very easy to label it. But sometimes we are needing echo and MRI, up to MRI, to label whether patient is having structural heart disease or not. So structural heart disease, the treatment is ICD followed by ablation, or in add-on ablations. And if the patient is having only VT with normal heart, the first and foremost treatment is RF ablation, where it is a curative. Coming to the VT, it is not a uniform entity. So this is the one VT patient. You can see patient is only, this is the second VT morphology. And there is a third VT. If you see from very distance, you may say that it may be a sinus tachycardia, but this is also a VT. So the first VT is almost like a patient is developing VF, or it is more like a polymorphic. Second is more like a monomorphic, and third is a slow VT. And all has got its own problem how to manage this type of situation. So when it comes to the management of VT, the first and foremost thing we want to see what is the hemodynamics. And as you know, if the hemodynamics are unstable, cardiovert the patient. If you are having time, you should always give some, whether it is a monomorphic versus polymorphic, because the behavior of both the tachycardia will be different, and even the clinical etiology will be also different. And that's why monomorphic versus polymorphic makes a lot of difference in its behavior with the drug treatment. And sometimes you will end up in the problem if you are dealing a long QT and you are giving cardron or amidron, which is a very commonly used drug most of the time for the VT, that patient is developing the recurrent VT. This is one of the area of interest for that whenever VT happens, when it goes to the interventional cardio, they immediately say we will go to do angiography and angioplasty and the things will be resolved. But if you have come across or not, there are some condition in which After doing angioplasty, the VT is on running, and then they will refer to the electrophysiologist, or they will just plan to do the ICD also. So which patient we have to take for the angiography and which patient we have to refer to the electrophysiologist to take care for the VT, that is a very vital question, and I think it has to be answered. So if you are getting a VT in which you are getting a polymorphic morphology versus monomorphic morphology, this makes a lot of difference. So polymorphic VT and the patient is ongoing chest pain, these are the condition in which the ischemia is driver, and here if you are going to do revascularization or stenting or taking the primary, the patient's chest pain also relieves, and at the same time VT also gets relieved. But if the patient is having a scar and which is driving, putting a stent in a bystander coronary artery disease is not going to resolve. Even after doing the stenting, the patient will be having ongoing VT, and in that situation, you have to put the patient in ICD. If the patient is having multiple run of VT, it should be ablated followed by ICD, or if it is only 1 or 2 episodes where the structural heart disease is there, putting ICD followed by ablation will be a better option. Coming to the polymorphic VT, yes, polymorphic VT is also a different variant, which is more like a VF, and usually the metabolic or ischemia is the driver. So whenever the metabolic abnormality is there, we have to correct it, and if it is associated with channelopathy, then we have to think about the drug versus devices. Coming to the pharmacological option of the treatment, so I don't want to go into the things which always scare me and most of the persons when they have to come to the antiarrhythmic, what we call the classification, class 1, 2, 3, 4. But yes, we have to know something basics, that class 1 is a sodium channel blocker and class 3 is a potassium channel blockers, and 2 is the beta blocker, and 4 is the calcium channel blocker. And the behavior, or we can say the pharmacological profile of the each class will be having a particular area in which of the action potential where it is going to affect. So class 1 will be on the 0 phase, class 2 wherever we are giving this beta blocker which will be acting on the 4 phase, and the 3 will be on the later phase of potassium channel openers. But a new classification has also been added, that is the in which the class 0 has been added for ivabradine, and even class 2 has been again reclassified, including the agonist versus antagonist. And in the class D, the late sodium channel opener blockers has been added, like a ranolazine. And again, the class 3 has been 1, A, B, and C has been added in that. But it is more academics than important than a clinical practice point of view. Now, how to decide which drug we have to give in a particular situation? The first question, when it comes, we have to see the variant, polymorphic versus monomorphic. QT interval, channelopathy's marker means if we are getting a QT interval which is prolonged, the drugs will be different than if the QT is normal. And coming to the echocardiography, is if at all it is available of previous, it will certainly give some information, and that will provide whether the patient is having coronary artery disease underlying, or the patient is having hypertrophic cardiomyopathy as an underlying entity which is driving the VT. The treatment will be different. So the first and foremost, whether the patient is having polymorphic VT, and if at all we are knowing the polymorphic VT, the next question is whether it is a prolonged QT versus normal QT. If it is a prolonged QT, the treatment will be of like Torsades point is what we do, the correction of the metabolic causes. But if it is without QT prolongation, there are two situations which we have to think about it. Means if you are having a baseline ECG which is showing polymorphic VT running, and after that the baseline ECG or the just after when the tachycardia is over, we have to see how the ECG is coming. If you are getting a probably Brugada pattern or short QT, or the patient is having idiopathic VF history, or the patient is hypothermic, means after putting the patient in a hypothermia protocol, you may be getting this type of things. Means QT is normal, but almost on and off patient is developing VT. This patient's behavior, as well as the patient who is developing a recurrent syncope or initial phase of the ST elevation MI, will also behave in the similar fashion. Means the QT will be normal, but the patient is throwing polymorphic VT. If it is a polymorphic with prolonged QT, the treatment that we are knowing, that we have to take out all the drugs which prolong the QT interval. We have to keep the potassium between 4.5 to 5 milliequivalent. And this is one of the important thing. Wherever possible, you should give magnesium as much as possible, and you can go up to 12 grams in 24 hours. So under treatment is one of the reason, because magnesium is one of the membrane stabilizing drug, and if you are giving in that situation in a polymorphic VT, with prolonged QT, a lot of VT can be taken out. After that, if it is going on, pause dependent VT is coming, put the patient on the pacing and isoprenaline if it is not available. And if it is with a congenital beta blocker, non-selective with ICD or pacemaker, can be given the choice. Magnesium, I think it is very, very important. Magnesium acts at a very different level. Means it is a lot of time we get a call, sir, the potassium level is magnesium level is normal. Why you want to give? So let us be clear that there is a disparity between the intracellular magnesium level and the serum level. And 99% of the serum cation, means magnesium, is inside the cell. 1% is extracellular, and of that, 1 to 2% is available for the serum level. So that fluctuation is very difficult to know about it, and that's why it is better to correct it. Because in one of the study by the Sachin Sai et al, they have shown that the patient who was going for the ablation, atrial fibrillation ablation, 89% of patient was having normal serum level, but when they have done the buccal mucosa biopsy, the level of magnesium was low. So intracellular magnesium deficiency was one of the reason, even though with the normal serum level. So whenever possible, give magnesium, and give it as much as possible. Up to 12 gram also you can go. Mechanism, we know that it has got a lot of membrane stability. It is more like a calcium antagonist, and wherever the calcium leak phenomena is there, it is going to act on the sarcoplasmic reticulum to stabilize it. Coming to the VT morphology, and depending upon what type of drug we have to choose. So there are two variants. We can say that the J-wave syndrome type of conditions like Brugada and early repolarization, and even some of the cases of some short QT syndrome. These patients, in this we are choosing the drug like quinidine, where it is very beneficial. And there are other conditions like CPVT, in which the drug, the drug we are using are flecainamide. So the polymorphic VT, whenever it is coming, and it is mostly in this type of condition, early repolarization, Brugada and short QT, and bi-directional VT, if it is happening in the long QT also, there we are having flecainamide. So quinidine is one of the drug which is not available in our country, but it is one of the drug of choice for idiopathic VF, Brugada syndrome, and malignant early repolarization and polymorphic VT in coronary artery disease and short QT. And why it become very important? Because this is the only drug which act on the I2 channels, which is the stage 1 of the repolarization. So none of the drug is having the activity on this particular channel, and that's make it unique. And that's why if a patient is having Brugada syndrome, he is not able to afford the treatment for this. If you put the patient on quinidine, it makes a life change in the patient. Though drug treatment is not advisable in a case of syncope or sudden cardiac death, but yes, this is the only drug when it has been administered in the patient with Brugada, the Brugada pattern over the time get changed, or it become normalized. That is the. Now coming to the cases, I will walk through 3 or 4 cases which is very vital. This is a patient who has been treated with the antiplectic for almost 5 years and been referred to us for the treatment. That you should do some EP study. Probably see complaints of palpitation. Seeing the ECG, I didn't find any very significant finding, but complaint of palpitation just alerted me for going for seeing whether the patient is developing repolarization abnormality like long QT, or patient is having any other condition. And to my surprise, the patient started throwing the VT, and this VT is almost like a polymorphic or bidirectional. And this patient was time and again it has been, means you can see from that a particular rate, heart rate, at 113 the patient started showing the VPCs, and these VPCs increased to VT, and finally the patient started VF, ventricular flutter like pattern. And immediately, this is the important, the bidirectional VT is ongoing into this patient, which is very typical at a heart rate of around 130 to 120 to 130, which this patient started. And this patient is diagnosed on the clinical ground on this is that she is having CPVT. So CPVT is one of the condition in which the beta blocker is the drug of choice, and non-selective beta blocker we prefer. Patient was kept on 40 milligram of propranolol and flecainamide 15 milligram BD, and after that there was no episode of collapse or syncope, and patient is doing fine for last 3 years. Before the corona, I have seen this patient, and still the patient is doing fine without any collapse. So that is the importance of one is TMT in the patient where you are suspecting any arrhythmic event, long QT and CPVT can be established. And flecainamide, you know that this drug can be given in the pregnancy also, and this is the drug which act on the sarcoplasmic reticulum. Whatever the calcium leak is happening, it take care for that. Only contraindication is coronary artery disease and heart failure, so avoid in those situations. Second patient is that is a 45-year-old patient, syncope, fever and cough, and they have been called for that patient is throwing VT. What to do next? We have given amidron, and you can see the patient is having polymorphic VT with a prolonged QT. These are the situations where we have not to give amidron, and this patient has been given magnesium, overdrive pacing, and finally the patient has been second day onward the patient's VT episodes was totally reduced. So offending drug, like in this patient, he was taking azithromycin with hypokalemia, which we have corrected, and correction of the. So we should know that where we have not to give amidron. So any VT, SVT you can give, but if the long QT, torsade, and irregular white complex tachycardia you are seeing with the delta waves in previous, never ever give amidron. You will lose the patient. In that scenario, if you are having white closed tachycardia, it is ibutylite is the drug of choice nowadays. It is available in our country. Amidron to be avoided. This is a third case, 58-year-old patient who presented with the coronary artery disease, PTCA done, ejection fraction 40%. And this patient has amidron and bisoprolol, and after that, if you can see, the patient started throwing the VT. 2 times they have shock for the slow VT, reverted. Stenting has already been done, as I told. When VT come, everybody do the stenting. After stenting, still the patient is having VT. This is a doctor's father. So then they have referred to us. And when we saw the ECG, it is a slow VT. And slow VT is the most difficult to control with the drugs. We put the patient on the IV Xylocard and amidron, and after that it has subsided, but later on again it was happening. We put the patient on the ICD and we went for the ICD for the VT ablation, and after that the patient has totally normalized. In this patient, the amidron was continued, and a lot of time people ask after putting the ICD why you are putting the patient on the antiarrhythmics. So we have to be very clear that all the patient in which the structural heart disease is there, we don't want to shock them with the ICDs. We want to reduce the VT rate so that it should always take the ATPs to terminate the tachycardia, and that's why antiarrhythmic has to be added, beta block has to be escalated as much as possible, tolerated, so that the VT episode should be into the range of ATP, atrial anti-tachycardia pacing, and patient should not receive the ICD, and that prevents the VT episodes also. So after putting the ICD, you have to continue on the antiarrhythmic whenever possible. Amidron, we all know about thing. Only one thing I want to point here, that pregnancy, it should be avoided as much as possible, and it is a reverse dependent. When the patient is in tachycardia, when you are giving, its effect may not come, and the time the patient is reverting to the sinus, its effect will, or you can say side effect will be what we call the reverse use dependent pharmacokinetics. Means that the time the effect is the heart rate is going down, that time the toxicity will come. So we have to be very much careful, and that time the hypokalemia, magnesium should not be there, otherwise the patient will go in the torsades. So what I was saying, use dependent and reverse use dependent. So when the patient is in, when the heart rate goes, that time the heart rate control, or we can say VT control, will be coming the class 1 drugs. When it is a class 3 drugs, the effect will be, it is more a preventive, but you are giving an acute state, it will not be effective. When the heart rate is coming, that time the long QT or repolarization abnormality will start appearing. So be careful. Coming to the maxillary, it is the oral equivalent of lignocaine or Xylocard what we give, and when it is added with amidron, it works in the refractive ventricular tachycardia. So wherever you are not able to tide over the VPCs or the slow VTs, you can try with this drug. It works very well. And sotalol is one of the drug which can be given for the fetal tachyarrhythmias, and it reduces the defibrillation threshold. It is one of the drug which is chosen for the ARVD, arrhythmogenic right ventricular dysplasia. But be careful whenever there is a patient's renal function is compromised. Less than 40, avoid it. Don't give it. 40 ml per hour per minute is if the renal clearance. Don't give it. Start with 40 BD and go up to 120 to 160 BD also. It is a very safe drug, but QT prolongation as well as renal compromise has to be checked on and off. This is a third patient. This is a patient who is coming with a VT, and after giving the shock, the patient is having some repolarization, some ST T wave changes in the V1 to V3 leads. When we have done in the second intercostal space, two space up, we got the clear-cut VT episode, what you call Brugada pattern, type 1. And this type of situation, the ICD is the treatment, but what are the things we have to do in this type of patient? Bradycardia is the usual driver, and wherever the patient, short VPCs will be driving this type of thing. So whenever the bradycardia is there, this type of tachycardia comes very frequently. And in this, the quinidine is one, what I was saying, the quinidine is one of the drug which works very well. Silostazone and isoprene is the one of the drug where we want to increase the heart rate to take care about the bradycardia dependent tachycardias in this type of situations. Fourth patient is a 46-year-old patient presenting with the palpitation. ECG is showing the RBV with left anti-hemiblock type of pattern, left axis deviation. The patient was given adenosine, no response, and after that somebody give the diltiazem. There was ECG abnormality, T waves was inverted, and this patient was done the angiography, and after that it was referred to us. So these are the situation in which calcium channel blockers work very well, and these are the fascicular VT. So it is a curative in this type of condition to give ablation and totally take out. A lot of patients with the diagnosis of fascicular VT, if the QRSs are wide and diagnoses have been kept on the ICDs. So calcium channel blocker before the curative, or you can say the EP study RF ablation can be given, and later on ablation is the treatment of choice and it cures the disease. So structurally normal heart with fascicular VT, the treatment is calcium channel blocker followed by ablation. This is the second last case which I will come across. This is a 38-year-old patient who has presented with recurrent syncope, no chest pain, and below is the ECG of that patient. He was given lignocaine failed, magnesium failed, amidron failed. And finally, if you see there is an ECG, there is no ST elevation. But whenever you are failing to give all the three drugs and you are having the opportunity to do angio, never miss in the polymorphic, as I told. Polymorphic VT, whenever it is coming, it is better to do angiography if the chest pain is there or the syncope is there. And in this patient, you can see the LAD was totally blocked, and the time we opened the vessel, the tachycardia totally reverted, no VT episode. So coronary angioplasty is antiarrhythmic in this type of situation. Finally, this is the last case. There's a 50-year-old male presented with a recurrent syncope. Primary PTCA done 8 days back, and check angio was done at the time of admission. That was also showing normal. And when you have put the patient on the amidron, magnesium, maxilatin, xylopart, everything has been given. The VT was ongoing. And if you can see, these are the, we call it short coupled VPCs, which is driving the VT. So these are the patients who develop the polymorphic VT with normal QT. In this scenario, whatever the drug you give, most of the time it will not respond. Ablation is treatment of choice. We have to take the patient. Primary ablation, what we call as, it is a very difficult in this type of situation, and putting the ICD with the diagnosis of VT, it will convert the patient into the shock box. What we call, the patient will be getting recurrent shocks. So the what treatment we can provide this type of patient, it is the quinidine. So all arrhythmic has been failed in this event. It is non-pause dependent, and it was starting with the one VPC, and this VPC is very narrow, so somewhat coming from the conduction system, we can say from the septum which was driving, and this is what we call the exact definition resistant refractory VT. And this type of situation, again, polymorphic VT, whenever we are coming, the drug is quinidine. So polymorphic VT, without prolonged QT interval, quinidine should be tried wherever possible. And in this patient, after putting quinidine, it was reverted. So early phase 2 depolarization is the cause, and calcium spark from the Purkinje's fiber is the cause, and quinidine take care for this type of arrhythmia. So coming to the closer of my presentation, let me make the things clear for everybody that if the patient is having VT and structural heart disease, just see from where it is coming. If it is from coming from a particular focus, outflow, fascicular or papillary muscle VT, ablation will be the treatment of choice. If the primary arrhythmia is the cause, like short QT, CPVT, long QT or Brugada, and the patient is having resuscitated sudden cardiac arrest, ICD is the treatment followed by drug treatment. If there is a patient is having underlying structural disease, the first and foremost always will be the patient. If it is a monomorphic VT, most of the time this type of patient we have to put the ICD, and if the patient is developing a recurrent VT episode, then we have to go for the ablation, drug treatment followed by ablation. So take home message: monomorphic versus VT versus polymorphic VT. See whether the patient is having structural heart disease. If the patient is having structural heart disease, forget everything, start with a amiodarone. When it is ineffective, you are having mexiletine, and some cases of ARVC where sotalol can be tried, or if the patient is having coronary artery, you can give these drugs. Only be careful whether the QT is prolonging or not. In that case, we have to see the cause and keep the drugs accordingly. If the patient is not having structural heart disease, patient is developing VPCs, multiple VPCs. So we are having the first drug as a flecainamide. If the patient is having fascicular VT, we can go by the verapamil, and if both are not responding, certainly if the patient is not ready for any ablation, we can go for the amiodarone as a drug treatment. Coming to structural heart disease, lignocaine can be given in ischemic heart disease, and after that we are having amiodarone. Quinidine is not available in our country. And if the patient is having no structural heart disease, again the flecainamide versus quinidine, these are the two choices we have to make. With this word, I will thank the chairpersons and course director that if any questions are there, I will be happy to answer. Sorry if I have skipped the time, in the constant of time, I have skipped 5 or 10 minutes extra. I am sorry for that.
Yeah, you can close this share part. You can share screen. You can close.
Yeah, thank you, sir.